Eduardo
Hola,
Rammaccoti, vascular surgeon here in Brazil. It is a pleasure to me to present at the Egyptian Venous Forum the future of DOACS and cancer-associated thrombosis treatment. Here are my disclosures. Well, it is not new that DOACS works to treat venous thrombosis associated to cancer. As you are aware of, in the past, we used to treat these patients with low molecular weight heparin, but given the commodity and the easiness of use of DOACS, we have tested them all against low molecular weight heparin, and the message for all these trials, the SELECT-D for rivaroxaban, the Hokusai for edoxaban, and now the Caravaggio trial for apixaban, is that it works like heparin. It's non-inferior and sometimes even superior, with a slight increase in bleeds, particularly clinically relevant, no major bleeds in gastrointestinal and genitourinary tumors. But they are already well established in the VTE treatment of cancer-associated thrombosis. What is new? Well, everybody asks us, can we decrease the dose after 6 months? As of now, no, we keep the full dose while we're treating cancer-associated thrombosis with DOACS, but there are 2 trials with the apixaban looking at reducing the dose to 2.5 BID instead of 5 after 6 months. They're called the EVE trial and the APICAT trial, and the APICAT is a big one in France with almost 1,800 patients that is checking if we can decrease the dose after 6 months for treating cancer-associated thrombosis with DOACS. This is not new, but we don't have this data yet. Another thing new, we probably will be able to treat cancer-associated thrombosis in children with a oral formulation of these drugs. We have now the data published for Xarelto with the Einstein for kids, and it's Einstein Jr. actually, not Einstein for kids. But the results are quite interesting because it compared rivaroxaban to standard treatment, whatever the physicians wanted to treat, unfractionated heparin, low molecular weight heparin, founder, or even vitamin K antagonists. And the message is simple. It works exactly the same without increasing bleeding, and there's the convenience of having something sweet, something oral, something in liquid format for kids. I know it's available in Egypt. It's going to be available here in Brazil pretty soon, and I think it's something new for DOACS. And now we have DOACS incorporated in the majority of the guidelines for treating cancer-associated thrombosis, either ISTH, ASCO, ESC, NCCN, and NICE. And we have this slight problem that is increasing bleeding, particularly in gastrointestinal tumors. So what's the big unmet need and what is the future? That's the theme of this presentation for DOACS and cancer-associated thrombosis. They work like low molecular weight heparin in a large spectrum of patients with VTE and cancer, with the advantage of improved practicality compared to injections, but the big unmet need is in bleeding. So we need to reduce the risk of bleeding, particularly in those patients with a tumor that is on the GI or genitourinary tract. This is the big thing. And what's the future for direct oral anticoagulants? We're testing factor 11A inhibition, and the rationale is pretty interesting. We have proved that in preclinical evidence that blocking thrombus formation, either with genetically modified animals or with antibodies or small molecules, we can decrease thrombosis with minimal bleeding. Then when we look at the human epidemiology, looking at patients with hemophilia C, they can tolerate the hemophilia without major bleeds, and these patients, they don't die by ischemic strokes and myocardial infarction. And in the opposite side, patients with elevated factor 11, they have 5 times more risk to develop strokes and myocardial infarction. So the idea of blocking factor 11 seems to be a good one, and it doesn't increase bleed. So given the fact that DOACS have this big unmet need in bleeding, maybe testing factor 11A inhibition would be a good way to go for cancer-associated thrombosis. We have now many companies producing factor 11A inhibition. We have small oral molecules, direct oral anticoagulants inhibiting factor 11. We have IV synthetic molecules. We have monoclonal antibodies, and we have the beautiful antisense oligonucleotide technology that blocks the synthesis of factor 11 by blocking RNA. So we have now 21 new molecules being tested, particularly for atrial fibrillation and for stroke. This is the main target for factor 11A inhibition. So now we're testing it for ischemic strokes, ACS. Maybe these 4 topics, it's on my brain, but I've been working with so many companies. We're planning to test in PAD. We're planning to test it for VTE prophylaxis in medically ill patients, and we're planning to test it for cancer-associated thrombosis. It seems to be a no-brainer. You have a big unmet need with bleeds, with DOACS, factor 11 inhibition seems to bleed less, so we will probably have the chance to test it in cancer-associated thrombosis. We have results now with milvexian. Milvexian is being developed by BMS and Janssen. Fantastic results for VTE prophylaxis after total knee replacement. There's this beautiful dose response, pretty much more effective than enoxaparin without increasing bleeding. So it's a promising drug. But the company that started testing factor 11A inhibition for cancer-associated thrombosis is Antos Therapeutics, 2 massive trials, the Aster trial and the Magnolia trial. Abelacimab, and remember this name, is a monoclonal antibody, single dose. It's incredible, that blocks factor 11A. And for the Aster trial, that are including cancer-associated thrombosis, all comers, all kind of thrombosis and cancer, almost 1,700 patients, is comparing abelacimab to apixaban, and the endpoints are non-inferiority for VTE recurrency and superiority for bleeds. And the Magnolia trial that is looking particularly in gastrointestinal cancers and genitourinary cancers and thrombosis. And it's being compared to dalteparin, and the endpoints are non-inferiority for efficacy and superiority for bleeding. So making a long story short, these folks think that this compound that is single dose or a dose every 6 months will work exactly like low molecular weight heparin, but without increasing bleeding. I think this is the big thing in terms of future for anticoagulation for cancer-associated thrombosis. So the takeaways for this presentation: DOACs, they do work to treat venous thrombosis associated to cancer, apixaban, edoxaban, rivaroxaban, but we still have this drawback with gastrointestinal cancers, history of gastrointestinal bleeds, and except apixaban with the lower bleeding rates for gastrointestinal cancer. Patient characteristics, we need to improve trials on that, but there's big room for the development of new targets, particularly factor 11A inhibitions. So that's my presentation. I'm very happy to be part of this very important meeting, and I would like to thank the organization for this very honorable invitation. This is my Instagram page. We provide free medical education in anticoagulation, and I'll be happy to see you guys there. Thank you so much, my friends.